we are going to look at how we can do a obstetric abdominal examination. Um, since we are in the middle of a pandemic, most of the medical students who used to come and do their day-to-day clinical activities in the ward cannot do that anymore. So we will be having reduced exposure to patients. So one other thing that is lacking is the clinical examination of patients that you used to do when the COVID was not there. So we thought of showing you how to do an examination, and we today going to look at how we going to examine patients with abnormal presentation. First of all, as any examination, we are sticking into the principles of inspection, palpation, percussion and auscultation. So we will be doing the same thing in obstetric examination as well. So we will be concentrating on the abdominal examination today, and our patient kindly agreed to participate in this clinical exercise. So first we take the consent. අපි පොඩ්ඩක් බඩ පරීක්ෂා කරලා බලන්න. First principle is to have an exposure. So පොඩ්ඩක් අපි when we are doing the exposure, we need to make sure that we are taking the clothes right up to the symphysternum and to the level of the pubic symphysis, just to cover her pubic hair region. And the first step in our obstetric examination itself, apart after taking the consent and proper exposure, is to do the inspection. In inspection, as you can see, the abdomen is enlarged, and this abdomen is symmetrically enlarged, and there is linea nigra, and there are few striae gravidarum. So enlarged abdomen with linea nigra and striae gravidarum, suggestive of that there is a pregnancy, and the umbilicus is flat, and if you look at closely, now you can't see much of scars, but in obstetric examination in particular, you need to look at the previous cesarean section scar. So you might need to pull the cloth little down and lift the tummy up, especially when the abdomen is slightly pentudous, and that's a suprapubic transverse skin incision indicative of previous cesarean section. And in particular, when it comes to obstetrics, you need to nowadays look for the scars in the umbilicus and in the either side where they may have undergone laparoscopic surgery. At the same time, you can look at the abdomen and see whether there are any visible fetal movements. Now, during this time, I could not see any visible fetal movements in this patient. Next step is to go for the palpation. Now, in obstetric examination, our purpose is to see whether the baby or the fetus is in the grown or the size is compatible, and what the presentation, lie and the position is, and of course the fetal heart sound present or absent. So first we want to check whether the fetal size is all right. So here in obstetrics, we check the symphysiofundal height as a proxy to the fetal size. To do that, first we need to find out the fundus. In doing so, we want to we will start the palpation by checking the fundus. How do we do that? There is a, if you take the symphysiofundal height, the fundal height error, we take it as 2 centimeters plus or minus according to the period of gestation. So the error is 2 centimeters most of the time. So which part we use to palpate the fundus? That's a common question that medical students ask, because various people use various parts of their hand. So if you take the palm of my hand, the palm is somewhere around 5 or 6 centimeters in diameter. So If you are to measure a margin of error of 2 centimeters, you cannot use a wider area. Therefore, we recommend you to use a thinner surface. We can use radial border, ulnar border, or even fingertips to check the highest point of the fundus. That is the first trick. The other thing is, now we are looking for the fundus, but within the fundus or the uterus there will be the fetus or the breech or the head, or the fetal part will be within the uterus. So, we need to first find out the first resistance that you are going to feel when you examine. That is the other thing when it comes to fundal examination. So, we start from the syphis sternum, that is the highest point where the fundus can go up to or go up to. The same principle applied when it comes to the examination of the spleen, where we start with the right iliac fossa, the liver we start from the right iliac fossa. That is where the highest place that organ can go up to. Otherwise, if you start in the midway, we are going to miss it. So, first principle is to start it from the syphis sternum. So, from that in this situation I use my ulnar border, because that is what I used to, but you can, of course, you can use your fingertips like that, or you can use your radial border like that. I do not think any harm doing that. So, use whatever you want to, but make sure that you use a border. So, from the syphis sternum you need to come down slowly about 1 centimeter by 1 centimeter. If you go more than that, then you are going to miss the fundus, and you need to be very gentle rather than pressing it deep. And when you do that, you will feel gently the first resistance that you feel, that is the fundus. If you press more like that, I will miss the fundus. Keep pressing till I get the next resistance, and actually that is not the fundus, that is actually the part of the fetus. So, if you measure from here to here, you will not get the symphysis fundal height, you will get something else. So, you start from the syphis sternum, come gently down until you feel the first resistance, and that is the fundus. Now, once you get it in the midline, you need to make sure the shape of the uterus by moving your hand along the fundus. That is to get the shape of the uterus. At the same time, you should be getting the highest point of the fundus. In this lady, the highest point is in the midline. Now, the next step is to measure the symphysis fundal height. Tape pick up. In the tape, we take the centimeter side downwards, we keep it like that, and then we measure gently with our thumb. We need to get the highest or the superior border of the pubic symphysis, and it is very important to look at her face. When you press on the pubic symphysis, sometimes you might cause pain, and when you check it, it is about 40 centimeters. Now, this lady's period of gestation is 38 weeks. So, that is compatible with the period of gestation. Right. The next step is to examine the lower pole of the uterus. To do that, now we are looking for the presentation, the fetus or the presenting part of the fetus. It can be a breech, cephalic, or something else, but whatever it is a large structure like that. So, to examine that, we use our palm of our hands, and we want you to appreciate that the fetus, the uterus is starting from the pelvis, now it has come up to the abdomen. So, actually the lower pole of the uterus is inside the pelvis. Therefore, we need to go towards the pelvis rather than coming towards the skin. The common mistake that you all do is when you are looking for the lower pole, you start from here and search for the fetus on the surface, which is not right. you need to go deep into the pelvis to feel the presenting part. So, how do we do that properly? So, still I use my hands, I keep my hands symmetrically on the tummy of the mother, and usually we start from the level of the anterior superior iliac spine like this. And when I press, now I am going to feel the presenting part in between my hands, and I am going to move my hands symmetrically downwards. While I am doing that, I will be looking at her face to see whether there is any pain. When I press down, I am going towards the pelvis like that, deep into the pelvis, instead of going on top like that. Right. Now, I felt a firm mass in the lower pole, but I expected, like usually the commonest presentation is head. Head is a hard round mass. Now, I am not 100% sure whether the lower pole is occupied by the head or something else. Now, the next step would be in this situation to feel for the upper pole. So, we turn ourselves like that, and then the same principle applied. I use my palms, I keep my hand either side of the uterus, I feel for the upper pole. Now, in the upper pole, I can confirm my doubt where I can see a round hard structure which is palatable, and I can feel the little constriction below the head, and then I am going to walk my hand through to feel for the back, stabilizing the same thing I am doing on the right side. I feel a board like structure on the left side of the patient, and I feel some knobby structures on the right side. Therefore, I think now this fetus is in breech presentation, where the baby's breech is in the lower pole, head is in the upper pole. Therefore, this is longitudinal lie, and the baby's back is on the left side of the patient. Therefore, this is left sacroanterior position. And while I was examining the abdomen during the palpation, I also felt the Leica volume, which you don't need to go back and do it again, and I think it's adequate. And then I am going to listen to the fetal heart. Now, listen to the fetal heart is again you need to do it properly. We still use the Pinard, I know. We have Dopplers, handheld Dopplers, which are easy. Just you need to place it on the mother's tummy where the anterior shoulder is, then you will get the Doppler reading. But when you are using the Pinard, this is the right way to hold it, and this side goes to the abdomen, this side is for your ear. How do we do that? We stabilize our mother's fundus using our left hand, and make sure, because we thought this baby is in left sacroanterior position. So, the head is here, the breech is here, the back is here. Therefore, the Pinard should go to the place where you imagine where the baby's shoulder is, somewhere in this position. So, I keep my hand on the fundus, I bring my head and take the hand out and listen to the fetal heart. If you want to count for the fetal heart sound, you need to count it for at least 1 minute, not less than that, because the fetal heart sound is so fast and it varies from 110 to 160. So, if you are counting, if you want to look at a watch or a clock, you can use your right hand to look at the clock. The end, fetal size. So, it is just a matter of estimation, and clinical estimation is not that sensitive, but however we tend to see by keeping our hands, and imagine the baby in your hand, and we estimate somewhere, I think this baby's weight is somewhere around 2.8 to 3 kilograms. And that's the examination. So now I'm going to complete the examination. Thank the mother and cover it up and make her comfortable. Right. So that's how we examine abnormal presentation. Now this was a breech presentation and with a normal frontal height.
Let's revise our knowledge on bony pelvis. The bony pelvis consists of two hip bones and sacrum. The two hip bones will articulate anteriorly with each other at the pubic symphysis, which is a secondary cartilaginous joint. The hip bone will articulate with the sacrum posteriorly and form the sacroiliac joint, which is a synovial joint. When we are looking at the bony pelvis, and especially the hip bone, we will find this hip bone made out of three separate bones. This is ilium, this is pubis, and this is the ischium. All three bones will come and lie and attach with each other at the center of the acetabulum. At the center of the acetabulum is displayed here. When we are looking at the hip bone, it is very important to remember some landmarks. Here in the ilium, anteriorly, we will find the anterior superior iliac spine, where the inguinal ligament will start. Anterior superior iliac spine will continue with the iliac crest. Coming down from the anterior superior iliac spine, we will have the anterior inferior iliac spine. From the anterior inferior iliac spine, we will have the superior ramus of the pubis. Here, we will have the pubic tubercle, where the inguinal ligament will attach. Then we will find the body of the pubis. The body of the pubis will continue down as the inferior ramus of the pubis, which will articulate with the ramus of the ischium and form the ischiopubic ramus. Here at the bottom, we will find the ischial tuberosity, which is very important bony prominence for the obstetric examination as well as for the sitting. When we are moving to the posterior aspect of the hip bone, here we will find the lesser sciatic notch. Then we will move upward where we will find the ischial spine. Again, the ischial spine is very important for the obstetric examination as well as for the procedures such as pudendal block. Here we will find our greater sciatic notch, and here we will find the posterior-inferior iliac spine, and here we will find the posterior-superior iliac spine, which will also again continue as the iliac crest. For the teaching and the academic purposes, we divide the pelvis into true and the false pelvis. This imaginary plane will pass anteriorly, starting from the pubic symphysis, then in the pubic crest along with the pubic tubercle, and then the pectinate line and the arcuate line of the ilium, passing through the sacroiliac joint and in front of the ala of the sacrum and the sacral promontory. So this plane will divide the bony pelvis for the academic purpose into a false and the true pelvis. This anatomical division, which is above this imaginary plane, is what we call as the false pelvis, which has a very little significance in the obstetric point of view, which will support the growing or the enlarging uterus. It is more important to know about the true pelvis, which is below this imaginary plane. Let's have a look at the true pelvis. For the demonstration purposes, I have removed the left-sided hip bone. The true pelvis is below this imaginary plane which I described before. Here we will have the pelvic inlet. Then we will have the pelvic cavity, and here we will have the pelvic outlet. When we orientate the hip bone in the anatomical position, where the anterior superior iliac spine and the pubic tubercle are at the same vertical plane, we will have an inclination of this pelvic inlet of 55 degrees to a horizontal plane. But when there is a sacralization where the fifth lumbar vertebra will fuse with the sacrum, this inclination angle will increase. This will lead to a bigger inclination angle more than 55 degrees. When you have a increased angle of this inclination, there will be a delay in engagement of the head of the fetus. Also, when there is a lumbarization of this L5 and S1, where the first sacral vertebra, which will fuse with the L5 vertebra and separate from the rest, this inclination angle will reduce. This will lead to an easy engagement of the head of the fetus. Let's go through the pelvic measurements. As I described before, we have the pelvic inlet, the mid cavity, and the pelvic outlet. At the pelvic inlet, we have the transverse diameter greater than the anterior posterior diameter. So this will facilitate the head of the fetus, if it is a cephalic presentation, to engage in the transverse manner. In the mid cavity, when you are looking at the pelvis, this anterior posterior, the transverse diameters are almost equal. But when you are looking at the pelvic outlet, we have the anterior posterior diameter, which is greater than the transverse diameter. So during the vaginal delivery, there is a transposition of the head from the transverse position to the anterior posterior direction at the mid cavity. Let's briefly go through the normal and its variations of the pelvis. The gynecoid pelvis, which is the quite normal and the most common variety in the Caucasian females. Then we will have the android pelvis, which is more or less equal to a male pelvis. Then we will have the anthropoid pelvis, which resembling that of an anthropoid ape with a much lengthened anterior posterior diameter and a shortened transverse diameter. Last, we will have the platypoid pelvis. This is shortened in the anterior posterior diameter and increased in the transverse diameter. Let's have a look at the pelvic outlet. The pelvic outlet, we divide it into anatomical pelvic outlet and the obstetric pelvic outlet. This obstetric pelvic outlet is an imaginary plane starting at the pubic symphysis. On either side, we have the ischial spines, and posteriorly, we have the fifth sacral vertebra. This narrow pelvic plane is very important for the internal rotation of the fetal head, which will enter through the pelvis in a transverse manner if it is a cephalic presentation, and then at the pelvic outlet with this internal rotation will have anterior posterior direction. And this imaginary plane is important for the pudendal block. When we consider the pelvic outlet, the anatomical pelvic outlet, when we have a look at this, as you all can see, it is a diamond-shaped pelvic outlet anatomically. The diamond-shaped pelvic outlet is made by this pubic arch anteriorly and posteriorly by the tip of the coccyx, and then on either side is by the ischiopubic rami, these two, and then we have the sacrotuberous ligament. So the pubic arch, the ischiopubic rami, here we have the sacrotuberous ligament and coming with the tip of the coccyx, which will form the anatomical pelvic outlet. Thank you.